It's 4 p.m. Italian time, so it's time for Food for Veins, Veins for Food. As always, we will welcome 10 seconds to allow everybody to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins and Veins for Food, a not-for-profit humanitarian and educational initiative that always starts with the art and heart of Monica Glowinski, dedicated to all the health professionals who have shown such a good heart during this tough COVID time, to which this humanitarian educational initiative is dedicated in support of the post-COVID lockdown economic crisis as requested by the publication on Lancet Journal. Nothing would have been possible without a truly stellar, wonderful group of professionals from all around the world and all the colleagues and friends who have joined us from all around the world in this teamwork. I take this chance to deeply thank Professor Homan and Garcia for their time in answering to all the questions of the previous webinar. You can find the answers in the website of the Win Foundation, as we will do also in this webinar. So I encourage you to write in the question and answer box, not in the chat, just in the question and answer box, your question. The ones who will score high will get the answer live. The other ones will be answered during the week in written form. Today we focus on the very important topic of compression. As always, we will provide the international CME credits, and we will enjoy two stellar faculty members, Professor Chi and Professor Cavezzi. And we will enjoy also simultaneous translation in Chinese, for which I remind you that if you want to listen to this webinar in English, you don't touch anything, don't push any button. But if you want to enjoy the simultaneous translation in Chinese, you push on the button dedicated to the interpreter, and then you choose Chinese, and then you choose mute original audio. I take this chance to deeply thank once again Professor Chi and also Professor Mosti for his involvement together with me in recorded video lessons as extra educational material in the VWin educational platform. And I take this chance to deeply thank once again Giovanni Mosti and also Lorena Grillo and the giant of compression, Professor Parsh, for serving today as honorary chairs. So wrapping up the take-home messages at the end of this webinar, but not before having enjoyed the precious comments and questions of the continental expert representatives who will introduce one by one during the webinar. As said, nothing would have been possible without a truly stellar faculty, but also wonderful individual donors and industries that supported the initiative with unrestricted grants. So I take this chance to deeply thank Amnold, Balton, Bayer, Medi, Servier, Sigvaris, and Tactile. Thank you all. I hope we will all be together soon in a food moment not dedicated just to humanitarian and educational initiative, but also to the social gathering together that today we could dedicate with a virtual birthday cake to our friend Alexander Floor, who is celebrating his birthday. I'm sure the best present we can give him is registering to his meeting in Vienna for the next year. At this point, as always, I pass the baton to the ones I consider family, also as top colleagues. So the mic is to you, Oscar, and then Willie.
Thank you, Sergio. Dear friends, it's a pleasure to be here again among friends and experts from all around the world. Let's enjoy another Sundays full of science. Remember, you can make questions in any language. Les recuerdo a todos los de habla hispana que pueden realizar sus preguntas en el chat durante la presentación. Bienvenidos una vez más a todo Iberoamérica presente en este evento. Sergio.
Thank you so much, Oscar. Willie, it's your time.
Good morning, good afternoon, good evening, everybody. Welcome to our sixth International Conference. Please enjoy the show. And like Oscar have said, if you have any questions, please go ahead and go into the Q&A box. 各位同道们早安、午安、晚安。今天是我们第6次的全球会议。如果您有任何问题，请您在 Q&A 箱里问您的问题，我们会有中文的翻译。Thank you，谢谢。
Thank you so much. And briefly, we will give the mic again to Willie, who will serve as keynote speaker today, but not before having enjoying greeting from our guest of honor. As always, we welcome somebody close to the Venus ward, but eventually not totally inside. And in this case, we have the representation of the wound healing ward. And of course, we always look for teamwork, particularly for that wound healing ward. And it's our honor to have as guest of honor, Professor Romanelli from the University of Pisa, as also president of the World Union of Wound Healing Society. The mic is to you, Professor Romanelli. Marco?
Thank you, Sergio. Thank you, Sergio. Good afternoon, everyone. It's a real pleasure to be here. I want to acknowledge, first of all, the great effort Dr. Sergio Gianesini is putting on this initiative, which is a truly worldwide international initiative. Today's topic is compression. And I like to remember everyone what my mentor, Dr. George Sherry from the Oxford University, was saying to me every day when I was participating as a fellow in his wound healing unit. He was always saying, under pressure, everything is possible. So today, I'm sure you're gonna listen from brilliant speakers, and I'm confident that compression is a topic with a huge amount of technology, which is increasing day by day. So I'm sure you're going to enjoy the topics and question and answer. It's really an honor to be here, and on behalf of the World Union of Wound Healing Societies, I wish you a very good webinar. Thanks a lot and welcome everybody.
Thank you so much, Professor Romanelli. As you know, we always couple the great keynote speakers with a huge artistic, sport and different professional figures. In this case, I couldn't be happier than introducing somebody that is a brother to me. Professor Chi, you know him as scientific director of the foundation, but he is also, of course, a top researcher at the University of California, Davis. He has developed many new venous technologies, and for this reason, we decided to couple him with Tesla. It seems to me the most appropriate figure. He's also one of the board of directors of the American Venous and Lymphatic Society, but first of all, he's truly a brother for me and also for Oscar. So it's a huge pleasure for me and honor to introduce his keynote talk about graduating compression in the thrombotic post-COVID ward. Willie, the mic is on you.
All right. Thank you, Sergio and Oscar, for having me go ahead and give this talk. Let's go ahead. Can you all see my slides now?
Yep, you're perfect.
Okay. All right. Very good. Well, again, good morning, good evening, good afternoon, everybody. I will be go ahead and talk about a topic that's quite timely. It's about COVID and compression use. I do not have any disclosure related to this talk. The agenda is actually quite simple. I'll be talking about the pathophysiology of VTE in COVID, and we will tie in the compression use in COVID. Now, we all know by now that COVID exerts its harm to the endothelium by either a direct effect or a systemic inflammatory milieu. And this is actually through attachment to the ACE2 receptor, which is ubiquitously expressed through our internal organs, including our lungs and heart and endothelium. And with that inflammation, at the end, we have reactive oxygen species that are created that created a milieu or cascade of clotting activation, arterial vasoconstriction, platelet activation, which are all the ingredients for thrombosis to happen. Now let's look at some of the published data. Both of these studies are from the Netherlands. First, let's go ahead and talk about this study on the right, which is a study from the Leiden University looking at 184 ICU patients, that the overall thrombotic complication rate is 31%, both arterial and venous. And the majority of these complications, about 81%, is actually pulmonary embolism. And there's a 13% mortality rate. And one interesting finding of this article is that the plateau period is from day 10 to day 15 when the maximum amount of thrombotic events had happened. Now let's switch over to the University of Amsterdam study looking at the same type of patient, the COVID patient, except that now we have the ICU patient, which is in red, and the ward patient, which is in black. And all of these patients actually receive low molecular heparin for thromboprophylaxis. And what you do see is the occurrence of the VTE rate is 60% in the ICU patient and 10% in the ward patients. The German autopsy study, which is widely debated online, show us that the overall death of COVID patient is from PE at about 33%, and 58% of COVID patient will develop DVT. Now the question is, will standardized thromboprophylaxis be given to these patients? Still 27% of patients still develop VTE, which is a very high number. Now let's put it in perspective. If you were to look at the published literature in the last 10 years, especially the critical care randomized trial, looking at dalteparin versus heparin, you can see that event rate is 5.1 versus 5.8%. Somewhat of a number, but certainly less than the 27% we see in COVID patient. And moreover, if we were to look at a cousin of COVID, which is the H1N1 infection that happened about 11 years ago, we can see that the overall VTE rate is about 13%. Again, despite of standardized thromboprophylaxis, although high, but certainly less than the 27% we see in COVID patient. So there are several hypotheses has been generated, one of which is that these COVID patients, they have elevated fibrinogen count, as well as low antithrombin levels. We all know that based on school, that low antithrombin levels could cause resistance to heparin agents, so could that be a factor? And a high fibrinogen count could reduce the effectiveness of prophylactic dose of heparin agent. So these are the hypotheses. But having said that, could we have gotten this all wrong? Because there's more and more signs pointing towards that the index insult to endothelium is a immunologic or immunogenic type of pathology rather than a hematologic coagulopathy. The term is the macrophage activation syndrome, and at the very bottom here, you can see that these are complement deposit within the alveoli capillary, and this is a biopsy or an autopsy data. But one thing I want to point out is that if you were to look at the hematologic differences between DIC, which we're all familiar with when we see patients with severe infection, as compared with COVID, and what you do see is that the difference is for DIC, you have a exaggerated elevation of PT and APTT, whereby for COVID, the APTT and the PT were mildly elevated, if not normal. But the fibrinogen count for DIC is very, very vastly decreased. But in the COVID patient, there is normal or slightly increased. The D-dimer level, as we all know, that it's elevated in both disease process. So there is a difference between COVID and DIC that we see. Having said that, the Yale University group under Alfred Lee had actually published this clinical data on the fact that, again, the process, the indexing insult to the endothelium may be an immunologic process, termed endotheliitis, endotheliopathy, rather than a true hematologic coagulopathy. And it's reflected by the specifically the markers for endothelial damage, which is outlined in blue and green. But if you were to look at some of the coagulopathy or the coagulation process, if you look at the antithrombin level, activity level, the protein C, protein S, and alpha-2 antiplasma level, you don't see much difference between the COVID ICU patient and the non-ICU COVID patient. But when we look at the endothelial markers, that there is some of a difference. In particular, the low soluble thrombomodulin level, when you have low soluble thrombomodulin level, the survival is much higher as compared with when you have high soluble thrombomodulin level. Again, somewhat resembling that of the D-dimer curve. Now, having said that, besides the high VTE risk, these patients are also at high bleeding risk. This is a study that came from Wuhan, China at the Renmin Hospital, looking at overall death. 6.1% overall COVID death in this particular study is related to hemorrhage, and hemorrhagic complication happening in about 81% of organ damage. Moreover, looking at the Guangzhou study that was published in Lancet using Padua prediction score greater than 4, and we all know that this is actually high risk for VTE, that 11% of these high-risk patients for VTE are also at high risk of bleeding. Now, how do I tie in compression using COVID? Well, I've been thinking about it and decided that I was going to talk to you about few of the meta-analysis and 2 prospective trial. This is actually one of the major meta-analysis that was performed last, I would say, a decade or 2. It was published 7 years ago in Circulation, 16,000 patients, 70 trials, both surgical and medical patient. And overall, what you do see on the bottom is that IPC is favored to control, and control meaning placebo, and this is actually for both pulmonary embolism and DVT prevention or prophylaxis. But if you were to look at IPC and TED, you see the same phenomenon, that in favor of IPC in terms of lowering the risk of DVT. Now, when we're talking about comparing IPC or intermittent pneumatic compression pump to pharmacologic prophylaxis, you can see that advantage that had gained no longer existed. In fact, there's really no difference between the IPC and the pharmacologic prophylaxis in terms of deep vein thrombosis prevention. And last but not least, when we look at systemic bleeding, which is actually a phenomenon that we often ignore, that you do see is that the IPC actually is in more favor compared with medical or drug-related pharmacologic thromboprophylaxis. Having said that, the second meta-analysis I'll be discussing is actually a Korean study, was published in the Korean journal, 8,000 patients with 12 trials, and looking at primarily medical patients. Now, I'm going to spare you the details of this study, but what you do see is that it doesn't matter if you get low molecular heparin, unfractionated heparin, or intermittent pneumatic compression pump, the IPC, they're all better than control in terms of lowering the risk of VTE. But looking at low molecular heparin and unfractionated heparin as compared to IPC, the drug therapy seems to have a little bit of an advantage in terms of overall VTE reduction. But as for bleeding risk, what you see that trend reverses, that control or placebo seem to be better than low molecular heparin and unfractionated heparin, which makes sense in terms of lowering the risk of bleeding. But comparing with IPC, that you really do not see any difference between the control and the IPC group as far as the bleeding risk is concerned. Now, the PREVENT trial, which was published about a year ago, it's actually a widely debated study looking at about 2,000 patients were randomized in 1-to-1 ratio to one of the 2 groups. The first group is a pneumatic compression group plus thromboprophylaxis, meaning either unfractionated heparin or low molecular heparin, as compared to the control group, which only got the medical or the pharmacologic prophylaxis with unfractionated heparin and low molecular heparin. And the conclusion of the study is that the event rate happened in 3.9% in the IPC group, and then 4.2% in the control group, which is the pharma group, with a p-value of 0.74, which is insignificant. And what this suggested is that adding IPC to pharmacologic prophylaxis may not offer the patient the advantage that we had thought in the past. Now, the second prospective study was published recently, the GAP study, was published in BMJ. And what you do see again, we have about close to 2,000 patients, 1,888 patients, or again randomized to 1-to-1 ratio to intervention, which is low molecular heparin only, versus control, which is low molecular heparin plus graduated compression stockings. And you have to keep in mind, this is a study primarily in elective surgery patient. The overall event rate happened in 1.7% in the low molecular heparin group, and then 1.4% in the low molecular heparin plus the GSC group, with a p-value significant for non-inferiority. Again, indicating that adding GCS or graduated compression stocking to low molecular heparin did not offer the patient the advantage that we had presumed the patient to have. Now, having said that, we do know that there is a small amount of bleeding risk, less than 1%, 0.5 to 0.6% in this GAP study. The last meta-analysis I'll be talking about is actually recently published about 2 months ago. It's actually published in the Nursing Journal, 7,000 patients, 8 trials, both medical and surgical patients. And what we do see is that the overall conclusion of this trial, IPC plus drug or intermittent pneumatic compression pump plus pharmacologic prophylaxis seems to be better than pharmacologic prophylaxis only in lowering overall VT risk. But if you're to look at the study more in detail, the advantage seems to be that of the surgical group, and that applies to both the DVT prevention as well as pulmonary embolism prevention as well. So what does this consensus say? You know, many of us sitting in the panel are part of this consensus. What we do see is that ICZ gave the consensus of a 2C recommendation for thromboprophylactic stockings in patients undergoing major surgery, 2B recommendation of thromboprophylactic stocking in patients where anticoagulants are contraindicated. But more interestingly, the conclusion also gave the fact that it does not recommend below the knee thromboprophylactic stocking as a sole method of DVT prevention, especially in the stroke patient. But lastly, in high-risk patient, a recommendation of both the stockings and anticoagulant thromboprophylaxis is recommended with a 2C recommendation. So what about IPC? Well, the 2014 AVF guideline gave a 2C recommendation of IPC use when other modality are not available or not functioning. And in the 2016, the European guideline gave a 1A recommendation of the use of IPC for symptomatic C3 to C6 patient when standard therapy has failed for 6 months, and a 2B recommendation for venous ulcer after 6 months, again, when standard therapy have failed. So ladies and gentlemen, the conclusion of my talk actually raises more questions than answers. There are more unknowns than knowns. We know that despite of adequate current standard thromboprophylaxis, COVID patients are still at high rate of VTE. We know that these patients remain at high risk even 4 to 6 weeks post-discharge. And then again, the concern for bleeding risk in COVID is real and something we need to watch for. Obviously, there may be a regional difference. The bleeding studies I have showed you thus far all came from China, so we do not have any accurate reporting of the bleeding risk in the Western world. The etiology of thrombosis may affect the compression efficacy, and as I have stated, that especially in pulmonary embolism in these COVID patients, it may be an in situ immunologic index insult rather than a thromboembolic phenomenon. So until we have a better handle on VT rate in COVID, all tools, including intermittent pneumatic compression pump, as well as stocking, should be available at the hands of the healthcare provider. And with that, I want to thank you all for listening.
Thank you so much, Willie. I ask Khaled to allow my sharing. I'm truly honored to be your friend, particularly after these scientific performances you always show us. And this is the time to have the World Scientific around, starting from Europe. As you know, we always welcome a representative from the different continents, and it's my pleasure to pass the mic to Professor Bottini to introduce the continental top experts from Europe. Oscar?
Yes, let me introduce Dr. Jean-Patrick Benigni from France, a big expert in compression from the International Compression Club. Dr. Benigni?
Unmute yourself, Jean-Patrick. You have to unmute your mic. Jean-Patrick, can you hear? Yes, great.
Correct? Okay.
Hi, Jean-Patrick.
Okay. I would like, first time, I would like to thank Dr. Gianesi to have invited me to comment your presentation of Dr. Chi. Willie, I'm very glad to be here to listen your presentation. Somewhere, your topic is difficult because you explained us that the COVID provoked two direct targets. The first one is endothelium, and the second one is systemic inflammation. And in fact, my question will be very simple. What would be the rationale for using a compression stocking or graduated compression stocking for prevent DVT?
That's a great question, John Patrick. I think that specifically for COVID patient, I think graduated compression stockings will be very important, especially in the post-discharge period, because based on studies, which I did not have time to show, that these patients, even after discharge, remain at high VT risk 4 to 6 weeks after. So it's especially important for these patients to receive both graduated compression stocking, exercise, as well as possibly pharmacologic prophylaxis at the same time to lower their event risk.
Thank you so much, Willie. Now we fly all the way to Asia, and I take this chance to deeply congratulate Willie also for giving such a brilliant talk at 7 a.m. in the morning, as I deeply thank Professor Mo for being with us so late in the night in Japan. So Professor Mo Makoto from Yokohama University, and another huge expert from the compression world, and not only. Can you hear us, Professor Mo?
Can hear. Yes.
That is great. If you want, I can keep the slides that you asked me to show
okay.
everybody, and I will advance for you.
Yeah,
so if you want to make the question.
Yeah, thank you very much for the information of Dr. Chi. And
we are
high risk of VT are also high risk of bleeding. Next slide, please. Next slide, please.
Advanced.
Yeah, it's very similar to Japanese situation. When we use a pharmacological prophylaxis, we have a 4% bleeding risk. It's a very high bleeding risk. That's because mechanical prophylaxis mainstay of the VT prophylaxis in Japan. Next slide, please. And this is a mechanical prophylaxis increase after 2004 when the compression therapy was reimbursed by compression therapy by the government. So number of the mechanical prophylaxis compression increased rapidly in this period. Next slide, please. After that, this is the instance of PE. After 2004, the instance of PE drops sharply. So this demonstrates compression therapy itself is very effective to prevent the VTE, especially for high risk of bleeding patient. And next slide, please. And this is a question for Dr. Chi. Is pharmacological prophylaxis justified, especially by the therapeutic dose? I wonder this might cause a lot of bleeding. How about I think you are thinking to the VT prophylaxis with low dose anticoagulant and the compression. Is that correct, what you're thinking? Thank you very much.
Thank you so much, Professor Mo. Willie?
Thank you, Mo, for the two questions. First, I totally think that we need to throw at our patient everything we got. So I do agree that both pharmacologic prophylaxis as well as compression prophylaxis are needed. In terms of the dosing, I know that there are many institutions are actually currently conducting studies. We do not have any outcome data as to the type of dosing, whether it be prophylactic dosing, whether it be standard therapeutic anticoagulation, or half of the door basically non-bolus therapeutic anticoagulation. What do I mean by that? If you look at Tom Wakefield's group in University of Michigan, they actually use VT bleeding risk score to assess these patients. And in the type of anticoagulation they use, it's low molecular heparin at a prophylactic dose, heparin at a full dose, and then heparin at half dose, meaning that they do not give the bolus, but simply give the patient the drip according to normal gram scale. And I forgot your second question. The second question was about the compression use.
Yes.
Am I correct?
Yes,
Yeah,
that's
so I
correct.
think that the compression is certainly, based on the 2 randomized trial that was published thus far, are somewhat negative in terms of overall IPC efficacy. But I believe that the COVID patient is a little different because these patients are a tremendous elevated VT risk of at least 27%. So I think that there's not going to be any of us that would see the patient in that high risk group and then still not give the patient everything that we got, and that includes intermittent pneumatic compression pump use.
Thank you so much for brilliant question and answer. Now it's my pleasure to pass the mic to Oscar to introduce our continental top experts coming all the way from Mexico. Oscar? Oscar? Unmute yourself.
Yes, yes. Let me introduce my friend, Jose Muñoz, leading figure of the Mexican Society of Vascular Surgery.
Thank you, Oscar. Thank you, Sergio, for the invitation. And thank you, Dr. Shi, for your great presentation. The process of the thrombotic effect with COVID-19 is still not clear. And it's improbable for the venous stenosis have a very important associated with this problem. Maybe it's more associated to an inflammatory process. Then, what is the benefits of use the compressions in this kind of patients that the process is more associated to the inflammatory disease? For the other side, we have problems in the vascular, in the arteries too, with many acute ischemia for thrombotic events in the branch, arterial branch. Now we are working in the ICU with the indication to check the extremities each 4 hours and retire all the device to the stocks or the compression intermittent device. Remember too, the other territories with VTE are the arms, and the axillary veins are associated with this kind of patients. My question is, which is the parameters or what is the finding clinical examination or blood test to obligate to use the compression? Because I think the compression is a good idea in the ICU patient normal, but the COVID-19 patient is not a normal patient. They have a very big problem inflammatory you told about in your presentation. Then I think it's not clear the benefits of the compression in this kind of patients, and maybe could be problems with the use in the patient with acute ischemia in the extremity that this is common too in these patients. Thank you, Dr. Shi.
Well, thank you, Dr. Jose. I think that's actually a very thought-provoking question. So I'm going to answer in the best way I can. We do not have any current data on IPC or compression use in COVID, just because the disease process is overwhelming, but it only happened within the last few months. But one thing I want to point out too, if you're to look at the Hamburg, Germany study, that based on autopsy, 58% of these patients actually have concurrent DVT. So I think that that's something we have to watch for. And if you said, well, how does the IPC use apply in this particular patient? Yes, there are a lot of in situ pulmonary embolism formation, but IPC use would be primarily for the patient that developed DVT, which happened in 58% based on autopsy data. And as far as acute limb ischemia, that's actually very interesting, although it occurs less frequently than venous event. But what you have to understand is that IPC use, at least based on literature, we know that intermittent pneumatic compression pump, obviously at different interval, is actually a therapy for patients with acute or limb ischemia, if you're to look at the literature. So in fact, in the past, when we do arterial work on patients with limb ischemia, if they're not amenable to any type of surgical or endovascular therapy, that compression pump, all right, at different frequency, high amplitude, low period of these pumping function actually helps with improving their arterial function. So I don't think that using IPC in patients with critical limb ischemia in in that scenario would be, at least from my standpoint, is an objection. The compression stocking use may be a different story, but not the IPC pump.
Brilliant. Thank you so much, Willie. And now it's my true pleasure to welcome Dr. Redman, a brilliant vascular surgeon from South Africa and also founder of the South Africa Lymphatic and Venous Society. So Laura, the mic is for you now.
Thank you very much. Thank you for an excellent talk, and thank you for this invitation to present at this webinar. The Dutch study you highlighted reports high rates of venous thromboembolism despite heparin prophylaxis. Additionally, the COVID patients you mentioned have normal or high fibrinogen levels. Based on this, would you routinely monitor anti-factor 10 levels in critically ill COVID patients?
Well, that's a great question. I think certainly yes. When we put patients on anticoagulation, especially the heparin agents, you do want to use the anti-10A levels. Whether it be 0.3 to 0.7 for heparin or 0.5 to 1.2 for low molecular heparin use. You want to make sure that they're within the therapeutic range and not either above that range or below the range. So I do think, I'm pretty sure that that's actually quite standard. Obviously, that creates a lot of burden on the nursing staff, simply because of having to draw blood. So I think that heparin nomogram is also something that we're all familiar with. So I think it's very individual, institutional dependent. But from my standpoint, yes, I think that at least you should confirm the nomogram with the anti-10A levels.
Thank you so much, Laura and Willie. And now we move forward to the question and answer box. I was hoping that having Professor Wasila Taha with us, so unable to make question, Egypt was not getting the podium also this time. But in reality, Egypt is once again getting the podium thanks to Professor Rashad Bishara, who is asking you, Willie, is there evidence for the use of antiplatelets in addition to anticoagulants for the prevention of VTE in COVID? Challenging question.
Yeah, well, very challenging. Again, I don't have the answer as far as anti-platelet agents. Certainly is very enticing, but the problem is that what you have to understand is that there is certain amount of bleeding risk. And I think that the bleeding risk may vary, depends on ethnicity. Again, based on Asia, again, most of the study came from China, that the patients do have elevated bleeding risk, and what Dr. Mo also had presented with the Japanese population. So we have to be very careful in, I believe, population specific when we are adding on another antiplatelet agent to the overall thromboprophylactic regimen.
Thank you. Now we fly all the way to Brazil. The question is coming from Fabricio Jordan Santiago. For Dr. Chi, what is your routine of mechanical prophylaxis during hospitalization? IPC with compression or just IPC and then compression after discharge? And for how long?
Yeah, so our routine is actually the IPC use and then compression stockings after discharge, in addition to possible thromboprophylaxis. Obviously, we assess their bleeding risk as well as encourage them to be as active as they can, and physical therapy is actually involved with these patients as well after discharge.
We fly now all the way to Peru for the third and last one because time is flying. It's a pleasure to welcome Juan Valdivieso Chung. Question, in the case of patients with CVD and dermatological changes due to COVID infection, like COVID toes, is there any concerns about the clinical approach of compression stockings? Thank you.
The answer is no, because the type of COVID toes we're seeing are more like perennial, more of a sort of a Raynaud's type of phenomenon, and that actually reflects the underlying inflammatory milieu in these COVID patients. So as long as the inflammation is under control, the COVID toes should actually disappear. So I'm not concerned about using any type of compression devices in patients with COVID toes.
Thank you so much, Willie. It's time to move to the second round of the webinars, but not before applauding you with the more than 500 people who are listening here on Zoom, plus all the other ones of the socials. So thank you, Willie. Congratulations. I'm truly honored of being a friend and colleague of yours. And then thank you for answering the questions we haven't answered now and that are in the question and answer box. I'm sure you will do that in the next days. And then we move now to the second round, and if I had the pleasure of introducing Tesla before, now we will have the pleasure of introducing Guglielmo Marconi. For the ones who are not familiar with the radio, Guglielmo Marconi was the inventor of the radio, and he was from Bologna, where also Professor Cavezzi studied. So Professor Cavezzi needs no introduction. Like Marconi, is a big inventor. We are knowing him also for his experience with the long catheter. He's always into new things. Now he's all for nutrition and anti-aging, but we are looking forward for listening from a dear friend of many of us talking about adjustable compression reps, state of the art and future direction. Attilio.
Thank you very much, Sergio. I'm sharing my screen. Okay, so I can start. So thanks for the kind invitation. I will speak about adjustable compression reps and the state of the art and future directions. This is my disclosure slide. As you can see, there is no specific interference in the material I present here. So what's the meaning of adjustable compression reps? Let's say we are moving to self-management within the healthcare systems. And this could be a political reason, but also a knowledge-driven move, let's say, because of ergonomics, and because we have to take care also of the issues that the COVID and the new health system are facing. So if we look at compression, everybody knows bandaging, but of course, sometimes bandaging can be difficult, as you can see in this case. So how could we help people who are interested in bandaging, or as nurses or as patients and so on? On one side, we have to keep in mind that compression pressure in bandaging does not depend on the device only, but it depends on several variables, such as the professional, of course, the material, the technique, and so on. So somehow we could say that there is a kind of midland between hosiery and bandages, and this is adjustable compression reps. This kind of adjustable inelastic garments has been proved useful for venous and lymphatic disease, and it is also kind of an alternative device to bandages in general, especially useful for people who cannot wear stockings or just in combination with stockings. But especially, again, I reinforce the meaning, it could be a real option for self-management of the care of lymphatic and venous disease. So when we speak about adjustable compression wraps, there are a few models on the market. Still, we are waiting for more evidence, but what we know since the very beginning is that this kind of device may exert a very high interface pressure because of the composition of the tissue of this compression wraps. So a very high interface pressure, both, let's say, when walking or when standing, as you see from this slide from Giovanni Moschi. In this little summary, I tried to highlight how the adjustable compression wraps may have some advantages over stockings or over bandages. Because in terms of pressure, you may have some advantages, as you see here, which are similar to bandages. But when we talk about the maintenance of the pressure over time, and when we especially speak about cost saving and the possibility to involve the patient and not just the personnel, that's the question to choose probably the adjustable compression wraps. So if we look at literature, both Moschi and Parch demonstrated in this study how patients well educated to apply this device can reach a good pressure between 40 and 50 millimeters of mercury. And when they are asked to readjust, after 2 days, they keep the same pressure, or if not higher. In this elegant study from Protz, you can see a comparison between bandages and adjustable compression wraps, Circade in this case. And regrettably, bandaging reached only in 28.4% of the cases the targeted pressure, whereas the adjustable compression wraps reached the targeted pressure in 85% of the cases. And this is something to keep in mind because, of course, we are talking about a more standardized technique when dealing with the adjustable compression wraps. Another study from Ugo Parch, which has been recently published, showed that during a course, an educational course, in the second course, after teaching, let's say, the self-application was tested, and there was a very high level, 61.5 millimeter of mercury in, let's say, in the majority of the cases. So the pressure was absolutely around 50 to 60, as you see here, and never the appliers, let's say, went below 30 millimeter of mercury. So we tried as a group with Giovanni Mosti and Professor Paci to study, for example, in chronic edema. This is an article we published about 5 years ago in chronic edema. As you see here, we compare bandage with the Circade, and basically after 1 day and after 1 week, the edema reduction was higher, was better using Circade in comparison to bandaging. And also when we look at the interface pressure, as you see here in supine position after the application and after 1 day, Circade was able to keep the pressure at a good level, which was not the case of bandaging. And that's even more after 1 day or after an application when the patient is standing, as you see from this slide. Jean-Patrick Benigny and collaborators performed this study comparing the edema reduction, let's say using Circade followed by Circade, and you have still some edema reduction after the first intensive phase, which is not the case when you use stockings, 15 to 20 millimeter of mercury after a first cycle of Circade. So again, this is something to keep in mind. Let's move now to lymphedema. Damstra and Parch performed this very elegant study comparing compression bandaging with just a fit in this case. As you see, for example, in terms of leg volumes, let's say that after 2 hours and after 24 hours, the just a fit device achieved a better volume reduction in comparison, and this was statistically significant, in comparison to the trico bandage in this patient with the lower leg lymphedema. And measuring the interface pressure loss, that was higher for bandaging than for just a fit again. And again, they demonstrated a very good self-management of the pressure by the patient, as you can see here, and by the medical staff. So again, this is a possibility to keep in mind. In this study from Spain, they treated the breast cancer-related lymphedema, and it was a kind of non-inferiority study. And in fact, there was no significant difference regarding excess volume or symptoms between adjustable compression wraps and multi-layer compression bandage in this patient with the lymphedema of the upper limb. If we move now to ulcer treatment, you can see in this very old study from De Palma that treating patients with Circade or with ulnar boots, they found a slight better trend toward faster healing for Circade. Let's move now to Professor Villavicencio's group, and they published in 2005 another study comparing a 4-layer bandage with inelastic compression by means of Circade adjustable compression wrap in the contralateral leg. And again, they found a faster healing rate when using adjustable compression wrap. So for ulcer healing, they found a better outcome with this device in comparison to the bandaging. So in this elegant review about adjustable Velcro wrap devices for venous ulceration, the author somehow highlighted the quite interesting outcomes, but they also highlighted some lack of evidence. So somehow potential benefits for adjustable compression wraps were highlighted in terms of cost, nursing time, patient satisfaction, and potentially ulcer healing. They advocated some more studies to give more strength to their recommendation. And the musketeer Giovanni Mosti replied, giving more evidence, let's say. And so they performed, Giovanni Mosti and collaborators, the Miracle trial. They performed a multi-center Italian randomized clinical trial. And basically they compared Circade Just a Cure with a multi-layer bandage Coban 2 on a total of 66 patients affected by venous ulcer of the lower leg. During the 3 months trial, there was a classical local medication, followed by Circade in one group and followed by Coban 2L in another group. Of course, in the Circade group, the patients themselves readjusted the pressure when needed. On the contrary, in the bandaging group, there was the collaboration of nurses or doctors. So the results, in terms of healing rate and ulcer surface area, you see it was slightly better for Circade in comparison to Coban 2 layers, though the difference was not statistically significant. And when we look on the contrary to the material cost, this was clearly in favor of Circade in comparison to the bandaging. As you can see, a fixed cost for Circade is lower, statistically significant lower, when compared to the costs that the patients, or well, let's say the staff, had to cover for treating the patient in those 3 months. And I want to stress one point, that in this calculation, they did not include the cost savings derived from self-treatment. I mean, there was no caregiver in the adjustable compression reps group, which is another issue to keep in mind. The interface pressure and stiffness, as you can see, were similar in terms of interface pressure. And it was at the removal, of course, better for Circade than for Coban, as you can see here. In terms of comforts and side effects, let's say that slightly better outcomes were achieved through Circade, though the difference was not statistically significant. So in this study, a few very simple conclusions were that the adjustable compression reps were effective in comparison to inelastic bandages, very similar or if not better outcomes. There were no specific unwanted effects, and self-management was something very important which was highlighted because patients could help with the treatment, and that was an extremely important issue in terms of cost savings. More recently, in terms of COVID-19, there was an expert opinion article from our Turkish friends, and somehow everybody knows that with COVID-19, we have to shift from professional caregiver-based therapy to self-management. And that's why their recommendation was that we could shift from bandages to compression garments, or better to adjustable compression reps to treat especially venous ulcers. So going to nearly to the end, this is another interesting study from Poland where adjustable compression wraps were applied to a post-thrombotic limb, and through magnetic resonance, they were able to demonstrate that when through this device you overcome the pressure of 40 millimeters of mercury, then you can significantly improve the blood flow, which is an option in post-thrombotic patients, even also probably in DVT, but we are waiting for some data, and I know that some studies are coming. So I also found this nice letter to the editor from Kajati and Mander, where they evaluated the changes in ankle range of motion and plantar load with different compression devices. Basically, they highlighted that the higher the compression on the foot of the ankle, the greater the reduction of this ankle. So to make it short, they suggested possibly applying, for example, just a fit without the underlying elastic ankle would allow to have a nearly normal ambulation, and probably, as boropodometry did not change, could be a sign of a good function of the leg pump. So in conclusion, adjustable compression reps are a safe and effective device which can be used to treat venous and lymphatic disease and does not require expert personnel, which is something to keep in mind. Both ulcer healing rate, edema, and lymphedema can be treated with significant success by means of this device, which is well tolerated. And again, the cost saving is another proven feature of this medical device. That's why it could have a real role for the future. So I sincerely thank both Ugo, Giovanni, and Robert Damson for their help during my presentation. Thank you very much.
Thank you to you, Attilio. Wonderful talk. I ask for allowing my screen sharing, Khaled. So please allow me to get to our continental top experts. So we have Attilio has to stop his sharing, and if Khaled, thank you. And then we can move now to our World Scientific Round. We will start from Latin America, and it is my true pleasure to introduce Eduardo D'Amata and also congratulate him because he has just been elected Scientific Secretary of the ICC. He's a huge expert in compression, so we welcome his question. Eduardo? Eduardo, are you with us? You have to unmute yourself.
Yes, okay. Thank you, Sergio, for the invitation. Attilio, congratulations for your presentation, too clear as always. And as you know, we are working in the CIRCADE trial using the CIRCADE, the Velcro device in the acute phase of deep venous thrombosis, and in order to prevent post-thrombotic syndrome during a long period, during a year, using this strong compression. And concerning to the fact that we need high pressure of compression, more than 60 millimeters of mercury to neutralize ambulatory venous hypertension. And you showed us that it's possible to get with Velcro device. My question is, do you think we will see in our trial a decrease in the incidence of post-thrombotic syndrome with the use of Velcro device for a long period, a year in this case?
Well, you should give us the reply when you have the data. Let's say we expect that when enhancing the recanalization, we can also increase and improve the final outcomes, because post-thrombotic syndrome is due for sure to what happens into the veins, but what we know that it's also due especially to the pump, let's say how the patient goes after the DVT. So on one side, we expect that higher pressure will give a better post-thrombotic, let's say, course, but I have no specific data on this to tell you. Maybe Giovanni may know a little bit more, let's say.
Okay, we will have time later on for Giovanni during the honorary chair, and then we move on the way to Europe, and it's my pleasure to pass the mic to Oscar to introduce our friend Gerardo. Oscar?
Thank you. Let me introduce Dr. Jaroslav Stracek, head of the Czech Society of Phlebology. Doctor?
You have to unmute yourself, Gerardo.
Gerardo.
Unmute yourself. We will go back to Jaroslav later on if there are some technical issues. So I pass the mic now to Willie to fly all the way to Africa for somebody we all know and appreciate so much. Willie?
Yeah, next we have Professor Wasila Taha, who is the head of Egypt, Africa Venous Lymphatic Society. And really, we call her the Cleopatra of phlebology.
Hello, everybody. Confirm that you can hear me, yeah?
Yes. Perfect.
Hello, everybody. I'm really honored to be part of such distinguished scientific event and with a humanitarian perspective as well. Let me congratulate you, Willie, first for your excellent presentation. And now for Dr. Cavezzi, excellent presentation as usual. And I wish to see this opportunity to thank you very much for all you have done in our society in Egypt, really very early in this century. On behalf of our Egyptian vascular community, you bring us all your experience, your expertise and knowledge about the modern vein therapies very early in this century. We're really very grateful to you, Dr. Cavezzi. Now my question, I have been inspired by the title of your presentation, Attilio, and future directions. I wish that if you can highlight the role of the intelligent compression wrap with the microprocessors, with the sensors, with the compressible bodies embedded inside, and if you can add a real value to the conventional adjustable compression wraps. Maybe if your positive reply, maybe which candidate would benefit from such a new technology? Thank you, Attilio.
You mean which technology? Can you repeat just for a second?
The intelligent compression wrap with the microprocessors and sensors embedded inside the conventional ones.
Well, I mean, measuring is always interesting. So we have some possibility to measure, and even recently I saw a, photoplethysmography and during walking, dynamic, let's say, plethysmography, which would be interesting. Sorry, normal plethysmography during walking. But apart from this, I think it could be interesting for scientific purposes. Of course, we have some chances, and Giovanni Mosti and Ugo Pasch always stress the point that if you do not measure the pressure, then you should not perform any study, because it's a dose of a drug, let's say. So from the scientific point of view, for sure.
That is great. Let's try to fly back to Europe. Oscar, can you introduce our continental expert representative? Unmute yourself, Oscar. Okay.
Again, let me introduce Jaroslav Streczek. Now is that or not?
Yes, it told me it's there.
Yes, I should be on.
Yes. Gerardo, please speak.
Oh, thank you very much.
Here we are.
Dear Professor Gianesini, dear Sergio, is speaking your friend Gerardo, Jaroslav. I'm very happy to be here as a participant of this fantastic program in this very heavy period of the Earth, because we have a difficult time. So that's, you know, but we are very happy to have you here. Decompression is one of the most important activities in phlebology. So I understand that there are many trials to get a good compression to the patients. From my point of view, is to give the patient a compression tool suitable for his type of disorder, then to enable a self-service use, and then to have the option of individual adjustment of size and the change of size while the swelling edema reduces. So in my clinic, we have a little museum of phlebology. So we have very interesting things here. This is also an adjustable tool. We have another one here with a zip. And we also have a circuit here. So I will go to my questions. This is the self-service use, which is a little discutable in our hands, because in our unpublished study, we have achieved a success of application.
Please, Gerardo, go on.
Is there any problem?
No, it was Oscar having a Giovanni Mosti moment. Okay.
Okay. So, once more, we did a little study for us. How is the compliance high? My medical personnel was trained in applying the ACV on their own legs, and they succeed in 37%. When they applied it on the patients, they succeed in 55%, but the well-instructed patients, they succeed only in 17%. So we measured it very exactly in 4 points with a device, 4-channel, measuring the pressure in the ankle region and getting up to the knee. And what is not only to reach a compression at the ankle region, but to reduce the pressure to the knee to 70%. So this is my question. What I would like to ask is how the higher success of application has been reached in the other clinical departments than what have been mentioned here. And has my clinic been too strict in assessing the success of the application, measuring the graduated compression? Thank you.
Thank you, Gerardo.
Jaroslav, the question is that the teaching, an educational course to the patient, of course, to the nurses and to the doctors as well, but to the patient is mandatory. My own experience is that once the patient knows what to do, you have also a kind of regulator in the device, at least. I don't want to make any specific advertisement, but we have also a regulator which helps you to keep the pressure. And the patients are happy, as you told me, about the possibility to readjust when needed. So in my experience, we achieve very good, let's say, reliability of the final outcome of the final pressure through this device. Of course, it depends on a good education on the patients. Generally speaking, I would say it's a major advancement for the involvement of the patient, especially when you can standardize the way you put the straps.
Thank you so much. Thank you so much, Attilio. And now we fly all the way to Mexico for introducing our continental expert representative. It's my true pleasure to introduce Fernando Vega from the Tournai College of Phlebology. Fernando.
Hello, friends. Thank you, Dr. Sergio. Thank you for the kind invitation. Thank you, Dr. Attilio, for his excellent presentation. It's an honor to participate with you, that you are a great scientist in different areas. My question is, you have demonstrated the big qualities of the Velcro system. Sometimes applying the multi-layer bandage exceed the compression and cause injuries on an ulcer when this was known, especially in the flexion fold of the ankle. Has this happened with Velcro system in this part or in other place of the leg?
Well, personally, I had no specific injuries. Basically, the Velcro device stops at the level of the ankle, and you can or you can't include a foot part of the Velcro device. It's up to you. Otherwise, you have a sub-Velcro device, little stocking. So personally, I had no specific issues on injury. Of course, it depends on the pressure you use, but generally speaking, this was not an issue in my experience and also in Mosti and others' experience.
Thank you very much.
Thank you, Fernando. Thank you, Attilio. Now we move to the question and answer box, and we go back to Fabricio Jordan Santiago. Do you think necessary to know which interface pressure the device is giving during its use is meaning the adjustable compression rep, especially when considering its use in arterial patients?
Well, yes, when you use any compression, you should know, first of all, which is the condition of the arterial system, generally speaking, but that's not my topic today. So once you decide which pressure you want to apply, you can on one side have the help of the regulator, again, which helps you how to put the straps. And then if you may measure the pressure, such as a picometer or whatever, then you are on a safer side when treating peripheral arterial obliterating disease patients. But generally speaking, this is a stiff device, so there is a very low rest pressure and very high working pressure, which is a little bit reassuring, let's say, also in case of arterial patients when they are not in a critical limb state, of course.
Great. So we have once again Professor Rashad Bishara is asking you, how do you handle venous ulcers which are located distant to the adjustable compression rep?
Sorry, can you repeat the endothelial?
How do you handle an ulcer that is located distal to the application of the rep?
Yeah, I mean, again, when you use this kind of a device, you can use the foot part, which includes, of course, also the ankle part and so on and so on. And so in the case of ulcer, this could be an option. But again, you have anyway stocking, which is exerting some pressure on the ulcer area on one side. And the major effect of the cercade of adjustable compression bra is on the calf muscle pump, which is, of course, the most important effect we look for when treating venous ulcer. But I reassure that we can use in venous ulcer, especially including the distal part, and also through the stocking, which is under the cercade.
And it's my pleasure now to introduce the question from Lowell Kabnik, needs no introduction, a pillar also of this project. So thank you also for having an honorary chair of one of our webinars. He's asking us something that is actually really dear to me and Erika Menegatti. With the advancement and understanding compression, where are we with hydro compression?
Hydro?
Yes, it means water. As you know, like publications.
With Giovanni Mosti, he can reply again also to this question because they are working, and I know that also you, Sergio, are working on this kind of possibility. So that's an option, of course. I mean, it's a different compression because you are working on the neural fibers in that case, which is another interesting effect on the autonomous neural system, not only exerting a compression, but also working on the microcirculatory and neural effect. But I can't add more on the water immersion compression, which is an interesting point, of course.
Now the next question is about the progressive compression, Attilio. So thank you for your nice presentation. What is your opinion about the progressive compression? So when there is pressure that is increasing from the foot to the knee.
I mean, we have two kinds of compression. One is decreasing towards the heart, and also there was some articles again by Giovanni Mosti and Parch where they studied the compression which was slightly higher in the calf than in the ankle, and they demonstrated that it was also an interesting concept, provided that you do not create any tourniquet, let's say. So let's say that adjustable compression wraps somehow mimic what they propose, and again what Kajati wrote in that letter was showing as an option that also the foot could move better when you are not compressing too strong and reducing the normal gait, let's say.
So we are getting now a question from Juan José Vargas Carrasco. If I understand exactly what he's meaning, he's writing, is the leg compression a prophylactic care? Because COVID is a viral, inflammatory, and thrombotic ill. The pulmonary ground is in situ. Maybe what he wants to ask is if there is like some prophylactic action of this kind of compression.
Well, this is not a device created for prophylaxis, of course, because it may achieve a very high pressure, which are not needed as prophylaxis. And again, we have no data. I can't say anything more, especially in COVID patients or in any other issues. Let's say post-operative use, that's another story. We have done it. It could be an option because of the high pressure you may achieve, especially in the thigh, where that's not so easy with traditional compression devices.
And then we have a question from Jose Salas. I try to translate in from Spanish. In case there is an inflammatory lesion of the skin and there is an exudative ulcer, what would be the most effective compression methods according to your experience, Attilio?
Well, in terms of exudative ulcer, you may use all the local treatment you need, and then you can choose between a bandage and a compression stocking or an adjustable compression device. Of course, stocking would have some problems more, let's say, because of the fluid which comes out. So again, this kind of device, the adjustable compression wraps and bandages, could have an option, could be an option for sure. We need probably some more eccentric compression and some more material over the ulcer when there is such an exudation.
And then always Jose Sales is asking us in Spanish, what is the influence on the deambulation when we are using circade compression?
Well, there were a few slides where I clearly showed how the pressure increases during walking, and that's good because we can combat ambulatory venous hypertension well through this device, which could not be the case with the traditional stockings, especially when you have a very severe post-thrombotic syndrome, for example. So what we expect, as it is a stiff and low elasticity or no elasticity device, we expect a significant improvement of the hemodynamics with this device.
And since we have still a couple of minutes and we have answered to all the questions, I would ask you guys, Attilio and Willy, considering your expertise and particularly the one of Willy on interface pressure measurement device, how much can we or should we rely on the evidence-based data we have in compression, and how much we should also weight the risk-benefit in compression that is, of course, favoring the benefit because it's not so risky, comparing to the fact that in the literature, a lot of time we don't have a report of interface pressure in B and in B1. And it was demonstrated by Rothen that you can have the same interface pressure on the skin and a 50% variation in the subcutaneous pressure. So could you comment on this aspect between empiricism and evidence-based in compression science? Starting maybe from Willy with his experience with interface pressure measurement devices.
Yes, so that's a great question. So from our standpoint, as many of you maybe saw my work published in Phlebology and other journals, that we have been looking at various methods of detecting interface pressure or measuring interface pressure, but I think that we still have an issue with the sensor or the type of sensor that we need to do this. From piezoelectric and other form of sensing mechanism, and that has not been solved yet. So I think that until we have the actual device or the sensor being deemed to be sort of the standard, that is the first thing we have to do before we start to, let's say, for example, use interface pressure as some type of tools that we can move forward with different type of device measurements. So again, going back to what I said, I think that we're still not there yet as far as the sensing, as far as the sensor is concerned.
Thank you, Willie. Attilio, do you have a comment?
Well, very simply, what we need is to know the pressure. So whatever you do, I would suggest and would recommend to measure the pressure. And for the single individual, that would be reliable because it's the same device. Of course, if we talk about different devices, we might have different pressure, but anyway, we need to measure the pressure when performing especially scientific studies.
Thank you so much. And we are perfectly on time to move now to the honorary chairs. So it's my deep pleasure to welcome and thank for the hard work she's doing around the world, Lorena Grillo from the Flebo Latam group of Costa Rica. So now we welcome the take-home messages from the experts. So starting from Lorena in alphabetical order. Lorena?
Hi, how are you all? Thank you very much for the honor of this invitation and being able to participate with you in this great project, which I'm very fond of and very thankful for all the invitations and participation. And also for Dr. Chi and Dr. Gavezzi for the great presentations, which lead me to share with you maybe my take-home messages, which would be that systemic inflammation and endothelial compromise are definitely like key points, in this COVID-19 pandemic that we should look for. And they hold a special interest for us vascular surgeons in the moment, thinking about venous thromboembolism in the
You are breaking up.
but all
you're breaking up a little bit. Switch off the video. You have some problem with the connection.
Okay. So I think it's very important that now we only not be always like aware of the importance in that role of vascular surgeons and phlebologists in the prevalence of pulmonary embolism and deep vein thrombosis in the scenario of the COVID-19 patients that have high rates of mortality, high rates of ICU stays, and in the hospitalization wards also. That have been also, as Dr. Chi pointed, founded in the autopsy examinations, and also that after discharge, we have to be very follow up closely the patients after discharge of these COVID-19 patients in order to be able to optimize their condition when they're at home and promote awareness in the follow-up in order to be able to prevent other chronic complications of the patients. I would also like to state that the use of intermittent pneumatic compression has been a key in the management of our patients, and not only the pharmacological thromboprophylaxis, and also the safety and the cost-effective option of the management with the patients using adjustable compression wraps in the scenario of edema involving venous or lymphatic pathology underlying. So thank you very much, and thank you very much for everything.
Thank you to you, Lorena, for the outstanding contribution inside and outside the webinar. Now we pass the mic to Giovanni Mosti. Needs no introduction, plus we have also listened to him during the previous webinar at the opening. Giovanni?
Hello, Sergio, and thank you again for your kind invitation and for, I need to congratulate you for your brilliant initiative. I also want to congratulate with the speakers today regarding their really amazing presentation. And especially Willie, who had a hard task because COVID is a very new thing, and involvement of veins in COVID is also something very new. So Willie, congratulations, you gave us a brilliant overview of what we know regarding COVID and venous involvement. I was a little bit surprised by the number of observations you had regarding compression in COVID, because if COVID is mainly inflammatory, maybe these observations are concerned the fact that the compression is not useful in inflammation, and this is not the case, because compression is very useful in inflammation. So you took the right point. We know that compression is able to decrease inflammatory mediators like interleukins, and it is able to increase the anti-inflammatory mediators. So could be really have a role also in COVID. Obviously, we don't have any data. You underline very well this point, and we need to have data, but at least is a good way to start. So really congratulations to Willie. And regarding the presentation of Attilio gave us a brilliant overview on adjustable compression wraps. I have no specific comment on these. I would like just to underline two very important points. One is effectiveness of these devices. Every time we compare inelastic bandages and Velcro wraps, we see that they are at least as effective, and sometimes, for instance, in edema and lymphedema treatment, adjustable compression wraps are even more effective. In the study we performed on venous ulcers, we didn't find a significant difference, as Attilio underlined, but it is also true that we decided to have a sample size, a proper sample size for cost and not for effectiveness. So maybe the statistical significance was not reached because of the small numbers of patients we enrolled. And maybe that with, because the tendency was for a better effect with adjustable compression wraps. So maybe that with a higher number of patients, we could have also had a difference in this sense. Last point, adjustable compression wraps, and this was really well underlined by Attilio, are very effective from a cost effectiveness. So I would say that the 2 points, effectiveness and cost effectiveness, are really the winning point of these devices. Sergio, thank you again for your kind invitation, and I'm very anxious to see and to hear by Hugo.
Thank you so much. Indeed, this is a wonderful, a special moment professionally, also on the human side. If we are here today talking about compression, is because we are standing on the shoulder of a giant who paved the way for us. So this is the true honor of having Hugo with us live with us. We will listen to some of his comments and slides, and then also a little greeting from him.
First of all, I would like to thank Sergio for his marvelous organization, which he did, and especially also for inviting me. As you can hear, my voice is a little bit broken. I hope you can understand. What I would like to do in my final remark is just to show you some clinical pictures mainly. No curves and no complicated slides. So these are candidates for compression treatment as we see it every day. And as you can see here, compression may be very effective. In 5 days, we were able to reduce the circumference of the leg by 5 centimeters. And I don't know another option, therapeutic option, which could do that. You see in the ultrasound picture, the water-filled clefts have disappeared completely. This is a girl with a lymphedema, congenital lymphedema, and she was happy when we could reduce the circumference of her leg to this on the right side, because she could wear jeans again. And this is what we call therapy phase, mainly based on inelastic bandages, and maintenance phase, compression stockings. Here you see an example of the laser, bilateral laser procedure. And you see there was no compression proximal to the bandage and no hematoma down. Here you see still the traces of the adhesive bandage we had. I wonder if we could have achieved the same nice result with a compression stocking. Venous leg ulcers. This may be the most important indication for good compression. As you see, we use high pressure. We can increase the pressure by padding this area to get good hemodynamic results. For achieving these results, we use mainly zinc-based bandages, as it was invented by Paul Gerson Unna last century. And Unna had a pupil, Heinrich Fischer, and he was the first who described these bandages, as I learned it from Unna, for therapy of deep vein thrombosis. So these are our preferred bandages as we still do it. Such inelastic bandages are not quite new. Before the stockings were invented, all our compression was inelastic, of course. Only when the rubber was invented, the stockings used rubber threads, and then the compression became elastic. Goethe was suffering from an ulcer, and he was healed by such a compression bandage. Taken over into a modern sleeve, non-stretchable cotton. And this is also an example for inelastic bandages. So the disadvantage of such bandages is that it's not so easy to apply them. You need strong compression, needs training. Eco devices may be a valuable alternative. They are self-applied, self-readjusted and inelastic. This is Sandra Shaw in my sauna, demonstrating the invention of her father. Her father invented Circade for her mother, Hertha, because she had untreatable swollen legs. So my take-home message is compression is not the compression. Not all the compression is the same. Proper compression needs adequate practical hands-on training. Hands-on training is necessary, which cannot be learned in a webinar, of course. So the ICC created compression schools. And you can see the address here written down. And here you see a picture of India, SCC school. Dr. Benini is doing compression bandage. And this is an example from Brazil, SCC school in Brazil. Dr. De Malta is showing good compression bandage. Okay, so thanks again for listening to me. I hope you understood what I've said, and all the best. Thank you.
And deeply thank you to Hugo, who is with us. Hugo, do you want to say a word? We are all listening to you.
So I hope that people could understand what I said to my broken voice. I'm really sorry for that.
No, we just enjoyed another ride on the shoulders of a giant. So thank you so much for being with us today. So now we will move toward the end of the webinar. So I will, as always,
first of all,
pass the mic to the ones I consider family and esteemed colleagues. So Oscar, would you like to say a last remark?
Thank you, Sergio. Always remarking the importance of education. I want to invite you to enjoy session next Saturday when the Big Win Foundation, together with the organizing committee of the University 19, will be offering an extended activity online dedicated to thrombosis and deep venous system. Will be online from 9 a.m. to 12 at midnight in Argentinian time. And we wait for you all. Thank you.
Thank you, Oscar. Willie?
Thank you all for attending. Again, good morning, good afternoon, and good evening.
I like your scientific and fast attitude. So I will conclude thanking once again all the ones who have made this initiative possible. I deeply thank Tesla and Guglielmo Marconi for having provided such splendid lectures today, and also for the time they will spend answering the question we didn't answer today. As said, life has always difficulties that can become opportunities. So you know that on August 2nd, we will not have Food for Veins because we don't want to overlap with the Venus Symposium. Dear friends, wonderful meeting that everybody should enjoy. So we will see you on July 26th. So next Sunday, we'll still have it, but on August 2nd, there won't be, and we will recover that session on August 30. But difficulties or opportunities to include further activities. So on July 25th, we will move the first step forward to the Winter Dubai, dedicated to IVUS and dedicated to deep venous management of thrombosis also. And since it's always a teamwork, we will be more than happy to do this twinning with the Buenos Aires initiative, offering also simultaneous translation in Spanish. So we will see you on Saturday and then on Sunday for the venous active drugs session. Talking about Dubai, you know that it is all focused about evidence-based data and fake news-free communication. So I remind you that on the Big Win Foundation website, you are all welcome also because the vast majority of the societies from all around the world are taking part in this more, let's say, initiative in fighting fake news. You can report fake news in whatever language you have counted in terms of venous and lymphatics, and we will take them into consideration during the World Expo in Dubai. I look forward for next Sunday to welcome stellar faculty as well on venous active drugs. I take this chance to deeply thank the more than 1,000 people that also today join us, and then we will see the numbers later on, but deeply thank to everybody for this huge effort in this humanitarian and educational initiative. So it's 5:30 Italian time, and it's time to say goodbye to all of you, and thank you deeply to all of you. Thank you so much.
Thank you.